So, as per the WHO report 2024, hepatitis C virus is a major public health problem because it infects annually around 1.5 million new people that are positive for hepatitis C virus, and around 58 million people are worldwide harboring hepatitis C virus viremia. And so why it is important? Because hepatitis C virus infection, only around 15 to 45% of the infected people are able to spontaneous resolution of the infection, and other 55 to 85% leads to chronic infection. So this persistent infection and persistent hepatitis over the 20 years, 10 or 20 years lead to cirrhosis in around 20 to 30% of the patients, and this also lead to SCC annually 1 to 4% in patient with cirrhosis. So how to tackle this important problem? First of all, to identify the infected cases by adequate screening programs, to treat with the highly effective treatment modalities, so that can prevent progression of hepatitis C virus infection to cirrhosis and related complications in the form of decompensated cirrhosis or SCC. So risk factors for progression of hepatitis C virus infections are well known: high viral load more than 5 logs, age more than 45-year-old, male sex, presence of obesity, presence of other infections like hepatitis B virus, HIV, significant alcohol intake and smoking. These are the risk factors that progress disease in patient with hepatitis C virus infection. So global burden of hepatitis C virus before the advent of DA treatment regimen, the estimated global prevalence was around 2 to 3, that was around 2 to 3% of the world's population was infected with hepatitis C virus. So this was higher in the underdeveloped or developing countries up to the range of 13 to 15%, and this leads to annual mortality around 3.5 lakhs of the people infected with hepatitis C virus due to cirrhosis and related complications. So as per the WHO estimate, Eastern Mediterranean region are the highest population that harbors hepatitis C virus, followed by Southeast Asia region, and around interestingly around 50% of the infected population are unaware of their presence of hepatitis C virus infection. So this study published in Journal of Hepatology 2014 showed that around 80 million of the people are infected, are harboring hepatitis C virus viremia, and predominantly this was seen in adult population, and less around 10 to 15% of the infected patients were in the pediatric population. The hepatitis C virus genotype 1 and 3 was the most common genotype reported in this study. The genotype 1 was more prevalent in the underdeveloped or developing countries as compared to the developed countries. China, Pakistan, Egypt and India was the most common countries that was responsible for more than 80% of the total hepatitis C virus globally. So, prevalence of hepatitis C virus in SEER countries, that is Southeast Asia region countries. So, this the WHO reported that this is around 0.5 to roughly up to 3% more prevalent in the countries of Thailand, Myanmar and Indonesia. From India, the reported study showed that variable prevalence from India from 0.5 to 4.7% depends on the risk behavior and state of the study. So this population-based study published in 2012, they screened around, they surveyed around 26,000 patients, door-to-door survey, identified the risk factor for hepatitis C virus in the form of substance use, prior surgery, immunization history, and other risk factors like IV drug abuser. So they screened around 5,000 patients and found that hepatitis C virus was positive in 5.2% of this population, and co-infection with hepatitis B virus and C virus was seen in around 5.9% of this screened population. So this another study from the state of Leh and Ladakh of 3,000 patients showed that hepatitis C virus uh, they screened the patient for hepatitis B and C virus and found that hepatitis B virus was the main cause of viral hepatitis in around 12% of the patient in this population, and hepatitis C virus seen in just around 1% of this screened population. So this is the largest data from India, a synthesis of around 327 studies of this meta-analysis. They showed that studies reported from various states of India found that high prevalence of hepatitis C virus was reported from mainly from Punjab and eastern India states like Manipur and Mizoram. So as per this meta-analysis, the community-based this difference is mainly the prevalence is higher in the states of Punjab, Haryana, and more in the states of East India. This is because of multiple risk factors like more use of IV drug abuse, more use of unsafe needle practices, and also more repeated blood transfusions. So, the synthesis result of this study showed that in the community and in the pregnant women, the anti-HCV seroprevalence was around 0.85%, and among the blood donors, it was around 0.44%. So, another study from India between 2000 to 2021, they included this is meta-analysis included 28 publications and found the variable prevalence of hepatitis C virus from 0.5 to 53% depends on the studied population in the form of risk, behavior, and states of study included in this meta-analysis. So, data from National Viral Hepatitis Control Program. The National Viral Hepatitis Control Program divides India into 12 groups, and this also reports that higher prevalence of hepatitis C virus in Punjab and East India states. And this report said that around 12 to 20% of the cirrhosis in India is because of hepatitis C virus, and 12 to 32% of the SCC cases are directly related to hepatitis C virus. The risk factor of hepatitis C virus as per the control program is presence of HIV and population who require multiple hemodialysis sessions, IV drug abusers, and requirement of multiple transfusions. Also, the hepatitis C virus as per the program is more prevalent in men and in the age group of 35 to 49 years, and also in the significantly higher in the tribal population as compared to other population. And higher risk of unprotected sexual intercourse in past 12 months was significantly associated with higher prevalence of hepatitis C virus in India. So, what is the prevalence and transmission of mother to child transmission and prevalence of hepatitis C virus in pregnancy? So, this meta-analysis showed that overall seroprevalence in pregnancy globally is 1.8%, and this is much higher in the opioid use group and pregnant ladies who are infected with HIV. That is about 51 and 4.3% respectively. Another study showed that of 26 studies, this meta-analysis of 26 studies, they showed that active HCV viremia was associated with higher risk of hepatitis C virus infection. More than 6 log of hepatitis C virus viremia was associated more than 5 odds of more than 5 risk of mother to child transmission as compared to lower hepatitis C virus RNA load. So, the diagnostic algorithm for hepatitis C virus in the high risk population or whenever it is indicated, we do HCV antibody, and if this is positive, then we do HCV RNA and we treat if the RNA is detected. But RNA is usually the first marker that is detected in the blood and antibody appears later. So, we may miss a proportion of the patient that may be harboring hepatitis C virus infection, and we may miss with the lesser sensitive assay like hepatitis C virus antibody. So, the newer innovative tests are hepatitis C virus core antigen that are in the diagnostic pipeline and still in the tool of use for the research. That showed it has sensitivity up to 99% and specificity of 100% for active hepatitis C virus infection. So, how to decrease the burden of hepatitis C virus? First of all, decrease the risk of transmission. Screening of high risk population with hepatitis that can have hepatitis C virus, and screening of pregnant ladies, donors, and general population for more than 18 years. If advent of effective treatment modalities, that is directly acting antivirals. So, the WHO aims to eliminate the hepatitis C virus by 2030, and with the decrease of the new infection rate by 90% and decrease of the deaths of the that is related to hepatitis C virus by reduction by 65%. So these are the various strategies by which WHO aim to eliminate hepatitis C virus infection by 2030. That is safe blood transfusion, safe needle practices, and testing implementation of widely available testing services, treatment with highly effective directly acting antivirals. India's initiative, the India launched National Viral Hepatitis Control Program that provides directly that screen all the high risk population for hepatitis C virus, and also provide directly acting antiviral treatment free of cost in few of the states. So ASLD and ITSA recommend screening of hepatitis C virus in patients who are older of 18 or more than 18 years. The patients who are high risk like IV drug abusers, male sex partners, and pregnant ladies. So how the treatment of hepatitis C virus evolved initially, the standard interferon and was the only available modality to treat hepatitis C virus. Then came ribavirin, then followed by peg interferon, and DH was launched in 2011. DH are available in India by after 2016. So DH has better efficacy. Efficacy of interferon and ribavirin was around just 40 to 70%, and efficacy of DA is around more than 90 to 95%. And lowers adverse effect. It has better tolerability, shorter duration of therapy, around 3 to 6 months, and simpler form of administration required for DA. So these are the various available directly antivirals. I will not going much in the detail. Sofosbuvir, Ledaprasvir, and Velpatasvir and Declatasvir are the most commonly used antiviral in India as per the National Viral Hepatitis Control Program. These are the recently available antivirals, directly acting antivirals in India. And so how we decide about treatment modality of hepatitis C virus? This is mainly as per the viral hepatitis control program. This is mainly based on the presence of cirrhosis or non-cirrhosis, presence of, in case of cirrhosis, whether it is compensated or decompensated in patient, and ideally we should use the pan-genotypic drug, that is sofosbuvir and velpatasvir. Genotype 3 is relatively difficult to treat. For genotype 1, preferentially we can use sofosbuvir and ledaprasvir. Sofvel is pan-genotypic drugs, and sofosbuvir declotasvir can use for the treatment of all genotypes except genotype 1 and genotype 4. Usually the treatment duration is 12 weeks, and it can be extended to 24 weeks, depends on the specific population and treatment failure. So WHO strategy in 2016 was to eliminate hepatitis C virus by 2030 by a reduction of the 90% of new incidents and reduction of the mortality by 65%. That was mainly based on advent of directly acting antivirals and efficacy of antivirals. So these are the various studies reported from India using of variable directly acting antivirals was associated with higher virus clearance in around 90 to 96% of the patients. So what is the prevalence post DA era of hepatitis C virus? It is expected to decline the prevalence of hepatitis C virus and burden of hepatitis C virus liver disease, because DA cures hepatitis C virus in more than 95% of the cases, and it lessens the burden of the disease, and it also lessens the risk of transmission of hepatitis C virus. Egypt was the first who applied DA treatment in their program and become one of the role model for other countries. And this global study showed that patients who treated with the DA treatment, this waterfall diagram showed that there was around 8, the global prevalence of hepatitis C virus was declined by 8 millions as compared to prior to DA era. So this Sankey diagram showed that Egypt, in the country of Egypt, the prevalence of hepatitis C virus was significantly lower as compared to after treatment advent of DA treatment in their national viral hepatitis control program as compared to prior to DA era. And so these are the main countries: Egypt, Pakistan, USA, who first adopted DA in their viral hepatitis control program. India actually, sir, so this study was published in 2020. So India implemented directly and acting antiviral little bit later, around 4 to 5 years later. So there is almost no decline of the prevalence of viral hepatitis in India, as per this global study. But so this width of the bar shows higher number of the patients. So we can see in Egypt there is significant decline of, and in other countries who implemented earlier. So India is the amongst the countries who implemented later on. So probably the effect will come later. So how to prevent mother to child transmission of hepatitis C virus? This happens in 5 to 15% of hepatitis C virus positive mothers. Ideally, one could avoid the pregnancy before treatment of hepatitis C virus, because as of now there is no guideline recommend about treatment of hepatitis C virus during pregnancy because of lack of the safety data. So this one of the study published from India from Sher-e-Kashmir Institute of 26 pregnant women who with the active hepatitis C virus viremia. They treated in the second trimester with sofosbuvir and ledaprasvir for 12 weeks duration and found that all the patients were responded at the end of the treatment, and their children's, no one had hepatitis C virus positive at the 6 month follow-up after the birth, and there was no obvious congenital anomaly was detected. So as per this study, sofosbuvir and ledaprasvir can be considered, though we need more larger data to claim that the DA are safer in patients, in the pregnant ladies, and there is no harm to the fetus, and no congenital anomalies. This this study, they compared the patient, they followed the patient with the person living with the HIV, and they compared, they basically included 4 countries: Austria, France, Spain, and Switzerland, Netherlands. So they compared the prevalence of hepatitis C virus infection before the advent of DA and after advent of DA treatment. So they all these patients were at the initial enrollment were negative for hepatitis C virus infection, and this diagram showed that after advent of hepatitis C virus infection, there was significant decline in the incidence of new infection in HIV positive population as compared to prior to the DA era. So this effect was time dependent, and also in the this there was significant difference between the prior DA era and the limited DA access and broad DA access period, and found that around 20% in the broad DA access period, when the full blown DA was launched in these countries, that around there was decline of the incidence around 20% on the annual basis. So what are the barriers to achieve the goal for hepatitis C virus elimination of WHO before 2030? This is the lower socio-economic status, so that the people are unaware of the disease, they are not screened for hepatitis C virus, they are not, the DA are not accessible because of the economic status, and there is poor screening of drug abusers, sexual workers, and male sexual workers, and poor implementation of the safe needle practices. So what is the outcome after DA era in patient with hepatitis C virus related to liver disease? So this Korean study, they included the patient from 2007 to 2021. So they found that the fibrosis was reversed significantly. The patients who treated with directly acting antiviral with all measures in the form of APRI-4 and FibroScan. Also, there was significantly less liver-related events in the form of hepatocellular cancer, liver transplantation, decompensation, and liver-related mortality in this Korean cohort as in the DA period as compared to prior to DA period. So there are multiple studies, but this study, a meta-analysis of 23 studies, they compared treatment with DA and interferon-based regimen. So they found that presence of sustained viral response was associated with significantly lower risk of hepatocellular carcinoma as compared to non-responders. Interestingly, SCC was lower in patients who received interferon, who achieved SVR and who received interferon as compared to who received DA treatment. So I will conclude and with takeaways. There is significant progress with DA in reducing hepatitis C virus burden globally and in India. This also caused reduction of the burden of liver disease in the form of reduce the risk of SCC and also reverse the fibrosis and cause less liver related events. Also, there are persistent challenge in the form of lack of awareness, lack of access to the screening and medical treatment to all, and also the cost of treatment is still high. So, strengthening the public health intervention and ensuring access to treatment for all population to achieve the global goal of hepatitis C virus elimination by 2030 is mandatory. We can implement opioid substitution therapy, needle and syringe program, and also micro elimination of hepatitis C virus should be implemented. Thank you.